morning, everybody, and thanks to AIOS organizers for such a difficult and tough show and connecting us from all the parts of the country. And right now we are face to face with each other. I'll be presenting the trauma cases, and trauma, as is one of the main parts of the ocular injuries for its morbidity and the visual loss. And I'll be presenting pellet ocular trauma, and pellet is a short gun which is used for controlling the crowds. It's used for recreation sports. Right now, you are seeing a patient of a pellet injury who has received pellet and has resulting in traumatic cataract and a vitreous hemorrhage within pellet. We are doing a 3-port pars plana 20 gauge vitrectomy. You can see that we are removing the vitreous scaffold from as a core vitrectomy. Then we are proceeding to the pars plana and removing the peripheral vitreous. And these patients, they have a difficult induction of posterior vitreous detachment, and we could not find any cause why in these patients the posterior vitreous detachment was not easily detached. Probably the cause was that most of them were either 18 to 12 years of age or even younger age, where the vitreous is quite gel and less of the liquid. Here you can see that peripheral vitreous is being cleared, and once peripheral vitreous is being cleared, we are now trying for a posterior vitreous detachment. One turn, second turn, and third turn, and now see the vitreous detachment is there. Once the vitreous detachment is induced, you just clear a pole of the vitreous, because if you leave any scaffold of vitreous in the vicinity, either in the posterior pole or the peripheral retina, it acts as a traction band and may result in a giant retinal tear. Once the core part of the vitreous is removed, we go to the periphery of the globe and with indentation clear even the last bit of the vitreous. Otherwise, it acts as a part of traction and may result in repeat retinal detachment. In pellet injuries, this has been a difficult vitrectomy because once we remove the vitreous, the posterior wound is leaky. So one has to maintain the intraocular pressure between 25 and 30 millimeters only. Otherwise, there is a leaky wound and it may end up in a phthisis postoperatively or a hypotomy. So pellet trauma or pellet vitrectomy is not that easy as we have seen. Now we have reached the position of a peripheral vitreous where the localized retinal detachment is there. You can see this retinal detachment pocket at 7 o'clock where the pellet is lodged, and this area is totally detached while the rest of it is all attached. We are removing the vitreous scaffold and vitreous attachment from its base and to the margins of the detachment. And now you will see that we'll go to the next step where whatever the vitreous is left over, it's removed. Once it's removed, we then remove the pellet from the surface of the retina. Here we're again stuck up with little bit of vitreous which is not coming up, and now you can see it's peeled off along with the streak of vitreous hemorrhage, and this retinal detachment is quite evident. The retinal detachment is localized. It's localized to 7 to 9 o'clock hours, and so it's not affecting the macula, and post-operative visual problem would not be there. But the problem is there is a lot of subretinal blood which has to be drained. Now the superior part of the retinal detachment part is being cleared. Here is the fovea, which is all clear, but the base of vitreous is cleared, and the margin of the retinal detachment, there is a little more attachment of vitreous. The vitreous, once it is removed, one is fully satisfied. One can use triamcinolone estronil 4 milligrams. Then this is another patient who had a pellet, who had primary repair, but still has traumatic cataract and high FEMA. We usually do it 5 to 6 days after vitrectomy, because that way the wound integrity becomes clear, and at the same time the media becomes clear. He also has a dense vitreous hemorrhage. We have removed the traumatic cataract. We have cleared the vitreous base. Now we are going to the posterior pole. You can see this is the subretinal pellet in this patient. We are dislodging it from the subretinal space into the vitreous. And once the pellet is in the vitreous, we separate it from the vitreous margins clear it from the vitreous tractions, because if we pull it with the forceps, it's going to pull the retina. Then what we do, we make a conjunctival flap, cauterize the base of the limbus, and make a 4.5 millimeter incision. This is a tripod forceps which was innovated here with this, along with the help of the Dr. Natarajan from Mumbai. And once we engage it, we increase the size of the wound and pull it out. You can see this palette, and you can see this palette has multiple faceted ball. Once we did it, we have to go for attachment of the retina, doing a fluid exchange, endo laser, and silicone oil injection. Right now, we are doing endo laser over the margin of the exit wound at the site of the perforation. This is another case who had a detachment previously and had a redetachment, and now we have reattached the retina and we're putting the silicone oil. Silicone oil acts as a tamponade and has to be removed after 4 to 6 weeks. Another case with traumatic cataract and the vitreous hemorrhage. Vitreous hemorrhage is much denser. Traumatic cataract has been removed, and we are in the core of the vitrectomy, removing all the vitreous. This is the biome that we use for visualization and see how dense the hemorrhage is. And in such cases, there is every chance, if you are not very careful, one may have a break in the retina or a large tear in the retina. What we usually do, we choose the nasal part of the vitreous, clear the whole of the vitreous there, and see the part of the fundal globe, and then proceed to PVD, and then remove it. Done. We have removed core vitreous, removed peripheral vitreous, but the situation is quite bad. There's a large tear over the macular area and with multiple hemorrhages. We have done a fluid exchange followed by a silicone oil injection. These patients are monitored post-operatively for development of the intraocular pressure, band keratopathy, but most of them are tackled by removal of the silicone oil. Doing these palate injury.
Dr. Tariq, request you to conclude, please. Your time is up. I'm sorry.
Responded. The conclusion about the study is around 1,500 patients of palate injuries were removed, and most of them were 18 years of age, and 30% of them had vitreous hemorrhage with retinal detachment, and 80% of the patients had 612 to 618 vision, while only 10% had less than 6.